A very big hello to all my dear students. So, how are you all? So, let's start orbit today. What are the topics that we are going to cover? Of course, we'll be talking about the anatomy of the orbit, what are the questions asked around it, right? Then we'll talk about proptosis, its classification and different types of proptosis. How do we assess proptosis? How do you measure it? Very important topic, thyroid eye disease. We will cover that also, as well as we talk about orbital cellulitis, cavernous sinus thrombosis, supraorbital fissure syndromes, what is Tolosa-Hunt syndrome and so on, right? And then we'll be talking about optic nerve tumors like gliomas and meningiomas and of course blowout fractures, right? So, and lastly, yes, eye removal surgeries. So, let's start. I hope you have given the heading orbit and you are writing with me and making the diagram. We'll make our first diagram here. What is the capacity? So, make the diagram. If this is the orbit, of course, the oversimplified form, right? This is the eyeball and this is your optic nerve. What is the capacity of the orbit? We will learn, make a Q here, 30 cc. Shape of the orbit, it is quadrilateral or pyramidal in shape. Quadrilateral or pyramidal in shape. Which is the weakest wall of the orbit? It's a double Q, guys, and please don't answer floor. Weakest wall we are going to answer is medial wall. ठीक है? Weakest wall, medial wall क्यों है? Why it is the medial wall? We are going to say this is because one of the medial wall is actually formed by 4 bones. And one of the bones is the cribriform plate of ethmoid sinus. This is the reason it makes this wall weaker, right? And prone to fracture very quickly. So, weakest wall is the medial wall due to, write down, cribriform plate of ethmoid sinus, due to cribriform plate of ethmoid sinus. What do you call this cribriform plate of ethmoid sinus? We also call it lamina papyracea. We call it lamina papyracea. Right? There is another question. What are blowout fractures? Now you will say it is floor fracture due to blunt trauma. So, the floor fracture due to blunt trauma, these are called blowout fractures. So, blowout fracture always we are talking about floor. Okay, we will take the details little later when we take the topic. Just we will learn here it is the blowout fractures are floor fracture due to blunt trauma. Right? Okay. So, this is how we start the chapter and these are the basics. Now, we come to the next slide. So, you should be very, very clear here that what is the apex of the orbit and what is the base of the orbit. So, this becomes your base of the orbit and apex is out here, right. So, we will not be confused. This is very, very important. Anatomy. Looking at this one, just keep in mind here in this slide, the takeaway is that the angle between these two medial walls, of course, are parallel to each other and the angle between medial and lateral is 45 degrees, right. So, the orbits are actually divergent. So, if we ask you the angles of the on the direction of the orbit, we will just learn like this that these are divergent orbits. Okay. Coming to the different bones. So, let us learn first, listen to me, that will make things easier for you to learn. We will first think together and of course, everything is written in front of you. So, when you talk about roof, let us start from the roof. Common sense, roof is, this is what? Frontal bone, right? And पीछे क्या होगा? Lesser wing of sphenoid. That forms the roof of the orbit. So, lesser wing of sphenoid and frontal bone is the roof of the orbit. Then comes the lateral. Now, think with me, this is which bone? This is your zygomatic bone. So, this is the zygomatic and behind is greater wing of sphenoid. This makes the lateral wall. These are made by 2 bones, right? Both are made by 2 bones. Then coming to the floor, this is made up of 3 bones. Learn like this, zygomatic from here, maxillary from here, at the back a very small triangular palatine bone. So, these are the 3 bones forming the floor. And coming to the medial, medial is formed by 4 bones. If we start from here, it is the frontal process of maxillary. Just behind that is lacrimal bone, the one that you actually make open during DCR surgery, right, where you cut during DCR surgery. Then behind the lacrimal is your cribriform plate of ethmoid sinus and finally we come to body of sphenoid, right, body of sphenoid bone. So, these are the 4 bones which form the medial wall. I hope you are learning it. Maxillary just behind lacrimal, then comes your lacrimal ke baad first maxillary, then comes your lacrimal, lacrimal के बाद ethmoid and then comes your body of sphenoid. right? It should have been written more in a sequence, but anyway, I hope you have understood this. So, this is the way we will learn what are the different bones which form the orbit. Here is the labeling, and if you look at it, it's all color coded, but I think that's the most simpler way of making you all learn. If you want to have a look at it, you can have a look at it. So, if you talk about these are the different bones, right? Of course, this is your infraorbital foramen. And what is optic canal? What is supraorbital fissure? This one is supraorbital fissure, and this is, so I think this slide is a better view to show you the realistic picture. So, let us learn from this one. This is your supraorbital fissure, right? This is the optic foramen. And what did you learn? We have made a diagram here like this and said that, okay, this one is the annulus of Zinn. Annulus of Zinn was a tendinous ring from where all the muscles are originating. This is a very common mistake. You all answer all the muscles originating. It is not. It's only the all 4 rectile muscles originate from annulus of Zinn. This is your exam question on anatomy. You should know this. And of course, this is your optic foramen. Optic foramen, what are the structures passing through the optic foramen? If this is your optic foramen like this, what are the structures passing? 2 structures, main nerve of the eye, main artery of the eye. Learn like this. Main nerve of the eye, we answer main artery is which one? Ophthalmic artery. And main nerve of the eye means we are talking about optic nerve. Okay, so optic nerve, ophthalmic artery. Right, these are the structures passing through the optic foramen. Anyway, these were the 2 questions I just covered here. Let's have a look at this slide here. This is a supraorbital fissure. This becomes your inferior orbital fissure. This becomes your inferior orbital foramen, isn't it? Which you just labeled. So, this is the infraorbital foramen here, right? Okay. Then, of course, so we all should know about the supraorbital notch, and this is the notch from where we are giving the injection in the peribulbar anesthesia, right? Yeah. So, this is the main clinical significance that we have to know. The rest of the anatomy you learn even more in detail in your anatomy part, but yes, and this is of course your infraorbital rim, you can say, okay. That's about the, now we come to another important thing is details of supraorbital fissure and infraorbital fissure. What are the structures passing through it? That is of course very, very important and asked in your exam. Let's make a diagram here. I think that's the simplest way to learn. If you make the 2, this is your superior and inferior orbital fissure like this. Then we are making this annulus of Zinn, and here is your optic foramen. And optic foramen, this is your optic nerve, and this is your ophthalmic artery. This one is done already. So, this is clear. Now, what they will ask you, of course, this is your supraorbital fissure, and this becomes your inferiorbital fissure. You just saw it, right? Now, supraorbital fissure, inferiorbital fissure, what is this? This is the superior ophthalmic vein, and this one is your, we'll make an inferior ophthalmic vein here. So, this is your inferior ophthalmic vein. Okay. The question that is asked in your exam is about nerves which are passing through the supraorbital fissure. What are the nerves which are passing outside the Zinn and what are the nerves passing inside the Zinn? So, if you look about outside the Zinn, what is the mnemonic to learn it? I think we all remember this. Tell me, the mnemonic is LFT. Okay, so the nerves which are passing outside the Zinn is lacrimal frontal trochlea. Please will not forget this. This is asked in the exam in the anatomy part. So, lacrimal frontal trochlea. Trochlea kya ho gayi? 4th nerve, isn't it? So, the 4th one is passing outside the Zinn. Then we talk about what are the nerves passing inside the Zinn. So, passing inside the Zinn, of course, is superior inferior division of the 3rd nerve, nasociliary nerve and abducens nerve. So, we will mark here, this is your superior division of 3rd nerve and this is your inferior division of 3rd nerve. Then, nasociliary, which is a in sensory supply, and your abducens is 6th nerve. So, if you think with me, motor supply 3, 4 and 6, it is the 3 and 6 which are passing inside the Zinn and 4th is passing outside the Zinn. Just keep this in mind. Okay? Okay. So, these are the things, and if you talk about the inferior orbital fissure, we should also know about inferior, one nerve is infraorbital nerve here, right, and zygomatic nerve. Okay. So, if this diagram is clear, we have actually covered 3 questions here. What are the structures passing through? What are the structures passing through optic foramen was one question. What is annulus of Zinn? Another question. And of course, this is the 3rd one. Hope it is clear. Okay. So, before we move further, Let's have a look at this animated picture as well to understand this figure. We have already made the diagram here. So, let's see this. So, when you talk about, okay, this is the medial side that this figure is showing you. This is the medial side. Of course, we are looking at the orbital apex where we are looking at superior and inferior orbital fissure. And what is this? This is your tendinous ring, annulus of Zinn with optic canal. Here is your optic nerve and ophthalmic artery passing through the optic canal, or we also call it optic foramen. Both are same. Then we talk about next is what are the nerves we were talking about. So, if you go inside the Zinn, these are superior and inferior division of the third nerve. And where is the fourth nerve? It is outside the Zinn. And of course, then comes your nasociliary and outside LFT, that is lacrimal, frontal and trochlear. Right. So, we won't forget that we have to actually learn it as LFT. Right. And of course, then comes your infraorbital nerve and zygomatic in the inferior orbital fissure. Right. So, we have already drawn it and we are clear about it. Come to the next thing. Give the heading fascias. So, if you talk about the fascia, the different fascia in the orbit, we will divide it into two. One is your, which is lining the periosteum of the orbit, we call it your periorbital fascia, right. So, one is periorbital fascia, second is your bulbar fascia, which further forms the tenons capsulum, right. So, bulbar fascia, this is forming all the facial sheaths of the muscles, extraocular muscles, number one. This is important point. Now, what they can ask you is, how is the eye stable in the orbit? What is the factor responsible for horizontal stability? What is the factor responsible for vertical stability? Yahi samajhna hai. So, if you talk about horizontal, these facial sheaths of the muscle, they form the check ligaments, and because of these check ligaments, there is horizontal stability, number one. Coming to vertical stability, so facial sheaths, it forms a hammock below the eyeball, and that gives the, that is what is called, first of all, what is that called? Suspensory ligament of Lockwood. Right? This will prevent any downward displacement. What is very important to learn here? All the facial sheaths are forming the suspensory ligament of Lockwood except for superior muscles, that is superior oblique and superior rectus. Right? And if this is a common sense, because it is below, superior muscle sheaths cannot form a hammock below, right? So, it is formed by all the, you will learn all from facial sheaths except your superior oblique and superior rectus. The superior muscles are not contributing to ligament of Lockwood. Now, pay attention, ligament of Lockwood has been your exam question. So, this gives the lateral suspensory ligament. So, it will prevent it to move downwards, right, and is giving the vertical stability, and I told horizontal or lateral stability is by medial and lateral check ligaments. So, if we look at the surgical spaces, let's again we will learn it in my style. We make a simple diagram, ye orbit hai. What are the surgical spaces? This is your eyeball, right. Now, all the muscles we have learned are from the recti originating from the Zinn, and the muscles are generally coming from apex of the orbit, of course, except for inferior oblique. So, they are coming from the apex of the orbit and they are being inserted in the eyeball like this, hai na? So, this space that is formed is conal in shape, and this is called intraconal. And here is another one, it is this one. Why? Because these muscles will be inserted on the fascia, that is that bulbar fascia or tenons capsule. So, now what are the different spaces? This is the, if this is the bone, this is the periosteum. So, this becomes subperiosteal space is one surgical space. Number one, this is your subperiosteal space. If you will draw with me, you will never forget. Hope you are doing it. This is subperiosteal space. Inside the cone, ये क्या हो गया? Intraconal space. Of course, if you want to draw full, if this is the optic nerve, of course, is here only, isn't it? Then this one we will become your subtenon space. Make this subtenon space. And this space is extraconal. ठीक है ना? ये वाला हो गया extraconal space. Now, what is the clinical significance? The peribulbar anesthesia is given in the extraconal space, whereas intraconal space may we go for retrobulbar anesthesia. Can you see it is a high risk of damaging the optic nerve if I am going to give a retrobulbar. Optic nerve damage is not a small thing, you make the patient blind, right. So, we generally do not go for retrobulbar, we prefer peribulbar, and retrobulbar is given in squint surgeries because we do not want the patient to have any oculocardiac reflex, isn't it. So, to block the ciliary ganglion, we can go for retrobulbar anesthesia. So, in special circumstances, we may have to offer retrobulbar anesthesia. Then we talk about next. Next is your, once we are clear with this, next we talk about what is proptosis. Talking about proptosis, it is protrusion of the eyeball, but we have to be very clear how much protrusion. And even with the nice big eyes, you can't say it is a proptosed eye, isn't it? It will be a little unfair. So, what is proptosis? We are measuring from the lateral-orbital margin to apex of cornea, and this distance of more than 21 millimeters or difference between the two eyes of more than 2 millimeters. What is the distance? Lateral-orbital margin to apex of cornea. This is how you define proptosis. So, how do you know what is the apex of the cornea? So, when I am showing light to your eye, the light is going to shine at the apex of your cornea. So, I just have to see that light reflects. Okay? So, this is how we define proptosis, and how do you assess whether the eye is bulging or proptosed or not. So, clinically, we can assess by, I hope you have learned this in your surgery also, what is Nafziger's sign. Have a look. So, what is this? How do you see this? The patient is sitting in front of you, you are behind the patient and you just raise his chin and try to see whether you can see both the eyes are visible at the same time or one is visible before. As in this patient, because the left eye is proptosed, this will be visible before. We see from the supraorbital margin, what is the protrusion? Okay. From the supraorbital margin, the protrusion of the eye is seen, measured, right. So, this is what is assessed qualitatively, and this is what is called Nafziger's sign. Okay. This is what is Nafziger's sign. Another way of just assessing in clinical examination is to look from front. And what is that view called? Sometimes they ask you this. This is called worm's view, right. Worm's view, again you can see in this patient the right eye is protruded. Now, what about exactly and accurately measuring the amount of proptosis? How do you do that? By this instrument, exophthalmometer. You are looking at Hertel's exophthalmometer here, right. Then, this is generally commonly used in adults. There is another name you have to be familiar with, and that is what is Lude's. Lude's exophthalmometer is mainly used for children. Just remember this. This is used for children. And if there is a non-axial proptosis, what is axial and non-axial? If the eye is protruding in the straight line, this is axial. If it is in different direction, it is called non-axial. So, that is also called dystopia. In that case, we can use, in case of non-axial proptosis, then in case of non-axial proptosis, what we can go for is Nagel's exophthalmometer. Just one additional point, this one has not been asked, but you have to know it. It is Nagel's exophthalmometer. It's always better to have one extra point here and there, right? Okay. So, this is how you measure proptosis. Now comes how to classify proptosis. You can classify it as, is it both eye or same or one eye, that is unilateral or bilateral? Is it painful or is it painless? Is it axial or it is non-axial, right? So, when you talk about this, let's take unilateral or bilateral, and if we talk about most common, I am just covering few important questions here, most common cause of proptosis, okay, in adults and in children. And of course, we divide it as unilateral and bilateral. How do you learn it? Let's learn it here only, unilateral and bilateral. This is exam question. So, adults, whenever they ask you the most common cause, whether it is bilateral, unilateral, axial, non-axial, painful, painless, always our answer is thyroid eye disease. Life is simple. Okay? Whereas in children, if they ask you about unilateral, we answer orbital cellulitis. It is, or we'll take this topic as well, orbital cellulitis, and bilateral we answer neuroblastoma. Okay, it is neuroblastoma. In bilateral we answer neuroblastoma. So just quickly cover this question because this was the train of thoughts here. So this is how you divide proptosis as unilateral, bilateral, axial, non-axial, painful or painless. Right. We next talk about what is pseudoproptosis. So when you say pseudoproptosis, it means it looks like there is proptosis, but it is not. That's what it means. So think yourself, as I just told you, big eyes, high myopia, number 1. Number 2, if the eyelid is retracted, it can give an impression of proptosed eye, or other eye is having ptosis. Either same eye is retracted or other eye is having ptosis, or other eye is enophthalmic, not in the position. It is mainly, it is enophthalmos means the eye is going inside. So it can give you impression that this eye is protruded. So that this is again a cause of pseudo, and of course shallow orbit. Another important cause is shallow orbit. So if the orbit is shallow but there is no other pathology because of which there is proptosis, this is also coming under pseudoproptosis. Okay. Next we start with very important topic, thyroid eye disease. So this is also called thyroid eye disease or Graves' ophthalmopathy or Graves' eye disease. So when you say Graves' ophthalmopathy, what are the points? Sabse pehle, this is an autoimmune disease, right? Common in females. So important point, autoimmune disease, more common in females. Write the way I am writing, please. There's a reason that I am writing and everything is not printed here. And there is always a reason why I draw along with you. I can get all drawings made and I can just talk, but I don't want to do that. I want you to draw along with me. So, autoimmune disease, common in females, and comes a very, very important, recently also asked, repeated question, so I make a double Q here. It is not related to level of thyroid hormones, and the patient can either be hyperthyroid or patient can be euthyroid, means normal thyroid level, more thyroid level, or patient could be hypothyroid, that is the thyroid levels are less. So, the level of thyroid levels are not actually related to the pathology. Either of the situation is a possibility, right? So, this is very important point to remember. That is also the reason if I am talking about investigating a patient of thyroid eye disease, thyroid level or hormone level, investigating the thyroid hormone level has no significance, isn't it? So, we generally go for CT scan and we need to peep in the orbit to see the changes. Just remember this. Anyway, we come to the next important thing. When you know all these 3 points, we talk about pathogenesis. First clinical signs. Let's first talk about clinical signs, then we'll understand why are these clinical signs. So, what are the clinical features? We 5 fingers here for you all. So, what are these 5 fingers? Proptosis, optic neuropathy, then myopathy, restrictive myopathy generally is happening, then soft tissue signs and lid signs. Okay? Write it the way it is written. 1 finger, proptosis. Next, optic neuropathy. Okay? So, optic proptosis, optic neuropathy, myopathy is restrictive. Restrictive means there is no palsy, it is mainly a fibrosis. Restrictive myopathy, soft tissue signs and lid signs. Okay? These are the important features broadly in a patient of thyroid disease. So, when there is a severe disease, of course, you start getting proper proptosis and optic neuropathy. But which is the earliest sign if they ask you? You will say the earliest feature is your lid signs, and the earliest feature has been exam question. We will answer it is lid retraction. So, earliest feature of thyroid eye disease, whenever they ask you, you will answer lid retraction. Lid retraction is also called, these terms are not obsolete, please. It is mentioned even in the latest edition of Kansky. It is called Dalrymple's sign. Lid retraction is Dalrymple's sign. Okay? So, once we know what are the main 5 fingers in thyroid eye disease, we come to pathogenesis. Again, we are going to learn according to my simple way. We make a diagram. This is your orbit, the eyeball, optic nerve. Make this diagram. Okay, let's start. Learn with me, learn along. there is an autoimmune reaction towards two things very important, thyroid cells and orbital fibroblasts. So, this has been asked, therefore, we are learning it like this, that autoimmunity कहाँ किसके against होती है? Against what? Autoimmunity against two important structures. One is thyroid cells, thyroid gland cells, and the second is your orbital fibroblasts. Okay, orbital fibroblasts. So, when you say thyroid cells and orbital fibroblasts, due to this autoimmunity, there are few things happening inside the orbital cavity. Now, write along with me. First thing that is happening due to this autoimmune reaction. Number one, what are the things that are happening? Number one is infiltration of inflammatory cells. So, because of autoimmune reaction, पहली चीज क्या हो रही है? There is an infiltration of inflammatory cells. Hope you have made the diagram. Next thing that is happening is enlargement of muscles. Now, why is this happening? Because of inflammation inside the muscles, different extraocular muscles. I am indicating only like this, but it means different intraocular muscles. So, there is enlargement of muscles. Of course, first it is enlargement and later there will be fibrosis. Third thing that is happening is multiplication of adipose cells. Lot of fat cells and adipose cells are increasing. Multiplication of adipose cells. And fourth you will learn is, fourth thing that is happening is increased secretion of glycosaminoglycans. Increased secretion of glycosaminoglycans in the orbital cavity. Now, because of all this, what happens? What is the capacity of the orbit? 30 cc. Now, the contents have increased so much. Lot of inflammatory cells, more of the adipose cells, more of the glycosaminoglycans, right? And of course, the muscle sizes have enlarged. So, what happens is, this capacity is still only 30 cc. So, what is happening? Increased in which pressure? Increased intraorbital pressure. And when the intraorbital pressure is going to increase, this is going to push the eye outward, leading to proptosis, right? This is the same reason this is going to also press on the optic nerve, and when it presses on the optic nerve, this leads to optic neuropathy. What happens when there is a neuropathy? Whenever there is a neuropathy, all the 5 signs of optic nerve disease will manifest, right? We have learned that in neuroophthalm, जब भी nerve बीमार होगी, whenever there is an optic nerve disease, there will be decreased visual acuity, visual field effects, afferent pupillary defect, decreased color, decreased brightness, right? So, all those features can manifest. So, if a patient is coming to my OPD, I am assessing her for the changes of thyroid disease. What is very important for me is to look at her pupillary reactions, isn't it? So, if her pupillary reactions are affected, there is an APD, then it is very serious. That means it is pressing the nerve also. The intraorbital pressures are very high. Got it? Let's take one by one. First is proptosis and optic neuropathy. In this situation, what to do, how to manage? So, if this patient has proptosis and optic neuropathy, it's all due to autoimmune disease. My first line of treatment would be, I start with systemic steroids, because I am fighting against autoimmunity, immune reactions, so systemic steroids, right? Once I have given the systemic steroids, if it is not effective, I can go with immunosuppressive drugs. If this is also not effective, this is my second line of treatment. If immunosuppressive, if I have to still go further, I go for radiotherapy. Note down here that it will use anti-inflammatory role of radio. Anti-inflammatory role of radio. And lastly, if nothing works, we go for surgery. Now, what surgery can I do? So much pressure is high, I have to relieve the pressure. That is called decompression surgery, right? So, next last resort is, we go for decompression surgery, right? So, when you talk about the decompression surgery, all of you, how do I decompress? I can't take out things out of the orbit. So, how will the pressure be less? When I increase the capacity of the orbit. Now, how can I do that? I break the walls of the orbit. Okay. So, breaking walls, it's a drastic thing. We break walls of the orbit to create the space and release the pressure. That is why you only do if it is if severe. Why? Because you want to save the nerve. You don't want this patient to land up into blindness. So, if you have to prevent blindness, you may have to go for such surgeries. Right? So, this can be 1 wall surgery, 2 wall, 3 wall, 4 wall is more theoretical. We don't generally, it's a very rare thing to do. So, 1 wall surgery, this is your exam question, which is the first wall to be broken in decompression surgery? We used to answer medial, but now we will answer deep lateral is the first wall. Okay. So, first thing that we want to do is cut the deep lateral. So, this is the first wall to be broken for decompression surgery is deep lateral. Suppose this is not given in your option, they don't expect you to know so much, then of course life is simple. It is first medial, then inferior, and then comes your lateral. Superior roof, as I told you, 4 wall surgery is rare. Okay. So, first we will, in this patient we start with medial wall, after deep lateral medial. If medial se bhi pressure nahi release ho raha, you want to release more pressure, you go for inferior, and lastly go for lateral. We had done deep lateral, now we are talking about rest of the lateral wall. Okay? Of course, MIL is, we all know, a mother-in-law, it's easy to learn this as a mnemonic. But of course, first, if deep lateral is given in the option, we will mark that. Okay? Okay. So, ये हो गया हमारा decompression surgery. Now, before I move further, what are the immunosuppressive drugs that we give? So, immunosuppressive drugs that you can go for is tocilizumab, infliximab, adalimumab hota है, adalimumab, it is not adalimumab, it should be, and teprotumumab. So, you know, of course, you just have to be a little familiar with the terms. I don't want you to really mug it up too much. But common names, you should know this, right? Now, this is against interleukin 6, this is against TNF alpha, this is against TGF, that is transforming growth factor, but not required to learn so much. Just know the names, that is enough. Next we talk about is restrictive myopathy, where there is fibrosis and not palsy. That is what is restrictive. So, whether it is a palsy or it is fibrosis, how will this patient present? Koi bhi muscle problem, any muscle problem, the patient always presents with diplopia and squint. Okay. So, very simple, life is very simple, DS, diplopia and squint. And how do you treat it? We go for squint surgery. This is how we will manage the myopathy, that we have to go for squint surgery. There is no strabismus surgery or squint surgery. This is the option. Now, before I move further, here only let us all understand what is the basis of any squint surgery. So, let us listen. Suppose this is the eyeball and this is the muscle attached. Again, in my simple way, if the action of this muscle is less, I cut and stitch it. So, if this was the muscle, I am cutting and stitching it, the fiber length is decreasing, the action will improve. This is called resection. Okay? Now, go to the other situation. Too much action. Suppose now this muscle, I don't want, this is too much action on the eyeball. This is overacting muscle, I mean to say. Ab kya karoge? Just shift its insertion backwards. So, going backwards is what? Recession. Just like economic recession, this is what? Muscle recession. Okay? So, make a box and learn it. It will apply everywhere. What is this? That in an overacting muscle, we go for recession, and in an underacting muscle, we go for resection. Underacting, we go for resection. So, that was about the basis. Now, what are the important questions asked in myopathy? Very, very important. First question is, which is the first muscle to be involved? Your answer should be inferior rectus. Okay. So, inferior rectus, and if I talk about the sequence of recti involvement, this is my simple diagram in which you can learn this. So, it is inferior rectus, then medial, then superior and lateral. This is the direction you should know about recti. So, exam question, which is the first muscle to be involved? First muscle involvement is, it is inferior rectus, right? Then another question, last muscle to be involved. They are the obliques. Everywhere in the standard books, it's just written oblique. But if you have to specify, then again it is the inferior one, that is inferior oblique. Can we remember this? Come to the next important question, which part of the muscle is involved? So, look here, which part of the muscle is involved? This is mainly this belly of the muscle is involved, right? Have a look. This is thyroid myopathy MRI, and this is the CT scan, and here again it is showing that it is only the belly. The tendons are spared, these tendons are spared, and it is only the belly of the muscle which is involved, right? So, this belly is involved. This is another exam question. We come to another one. Many questions there. You have a patient. You are saying that the first muscle is involvement, the first muscle to be involved is inferior rectus? Agree. Coming to an important thing, what will be the defective movement that this patient is going to complain of? Please don't answer depression. Of course, inferior rectus causes depression, but it's a fibrosis. So, actually even defective depression ke saath saath even elevation is defective. So, this is a question, which is the first defective movement complained by the patient? First defective movement actually is elevation. The first defective movement that we will learn here is elevation. One more question in myopathy. If a patient is coming to me with defective elevation, how do I know it is a palsy? By defective elevation, it could be superior rectus palsy or it can be inferior rectus fibrosis. How to differentiate? We go for forced duction test. What do you do in this test? Duction means what? Movement. Forcefully creating a movement to know whether it is palsy or it is fibrosis. This is what it means. Let's understand. So, I have a patient with a defective elevation. What I do? With my forceps, I will hold the superior rectus and try to move the eye slowly with the forceps itself upwards in elevation in the direction of the superior rectus muscle. If it is going easily with the forceps, definitely it is only palsy. But even with the forceps, if it is getting stuck, that means it's a fibrosis. Simple, common sense. So, this is called forced duction test. FDT here is forced duction test. So, forced duction test is mainly to differentiate what? Palsy from fibrosis. This is called forced duction test. Forcefully creating a duction. Right. So, these are the important questions. We next talk about is soft tissue signs. So, soft tissue signs give the heading. What is the first important thing? As you can see here, lot of periocular swelling, okay, periocular swelling you can see in this patient, appreciate here. And second of course is lot of chemosis, edema of the conjunctiva is called chemosis. Can you see that? Look at the chemosis here, okay. And then very important, asked in the exam is superior limbic keratoconjunctivitis, which means, yes, before I go further, this chemosis when so severe is called Enroth sign. This is what is Enroth sign. Note it down please. The next finding I said was SLK. This is an exam question where you are getting your superior limbic, only at the superior limbus there is congestion involving the cornea and the conjunctiva. So, it is a superior limbic keratoconjunctivitis. Just one liner has been asked. Where is it seen? You have to answer thyroid disease. Along with that, sometimes there can even be mucus deposition. So, what is the treatment here? We decongest it with adrenaline. We decongest it with adrenaline eye drops, or we can, for the mucus deposition, we go for acetylcysteine eye drops to dissolve the mucus. To dissolve the mucus, we will go for acetylcysteine eye drops. So, this is how you manage superior limbic keratoconjunctivitis. Another important term that we will learn here is what is your Goltzier sign is nothing but conjunctival congestion. So, chemosis is called Enroth sign and conjunctival congestion is what is called Goltzier sign. We next talk about is lid signs. We already know lid retraction is the earliest feature. So, first of all, why are you getting a lid retraction? Let's understand something. Let's talk first. We are saying what is the normal position of the lid? First of all, what is lid retraction? So, what is the normal position of the lid? Your upper lid is covering 2 millimeters of upper limbus, lower lid just touches the limbus. So, if it goes below its level, this is ptosis. Agar ye normal level of the lid hai, if it is going below its level, this is ptosis. And if it goes above its level, that is called lid retraction. Many of you answer proptosis, please don't do that. It is lid retraction, right? So, lid retraction means above its normal level. What is the normal level for upper lid? 2 millimeters below the upper limbus. Yes. So the first sign will be Dalrymple sign is the first thing, earlier sign, which is nothing but lid retraction, right? So this is your lid retraction. Then second lid sign that you will learn is von Grafé. So before I move further, let me also discuss one thing. Why are you getting this? I was talking about that. So one reason can be oversympathetic activity which is causing lid retraction. So that can only be applied when thyroid levels are more. But we have just learned that thyroid levels may be less, may be normal. So what is the main cause of lid retraction? The theory says inferior rectus fibrosis being the first muscle involvement, right? So when there is inferior rectus fibrosis, there is rebound. So this inferior rectus fibrosis is actually causing rebound overaction of LPS and superior rectus complex. Okay? So we all know now what are the two muscles which elevate the lid. You have discussed with me the normal position of lid. What are the two muscles which elevate the lid? LPS and Mullers. LPS is supplied by third nerve, Mullers by sympathetic. So we are talking about this is the main reason why you are getting lid sign. All these signs are due to overaction of LPS. So what is the takeaway? Overaction of LPS. And of course, there is situation in hyperthyroidism. If there is hyperthyroidism, yes, we can apply this theory as well, that there is more sympathetic activity. That means which muscle? It is overaction of Mullers. Then it is overaction of Mullers. But major part we have to learn is this one, right? So overaction of LPS being the main cause. One is Dalrymple sign. Coming back to the lid signs, what is von Grafé? It is lid lag. Do you all understand what is lid lag? So if you ask the patient to look up from up to down, the lid is following the eye. But if there is overaction, the lid lags behind, stays a little behind the eyeball. That is called lid lag, right? Then third is, let's first take Cocker sign. If the lid retraction is so much that the upper sclera is visible, like it's a staring look, right? That is called Cocker sign. So Cocker sign is staring look. And what is Stellwag sign? Stellwag sign is decreased frequency of blinking. Decreased frequency of blinking. What is the normal frequency of blinking? Around 12 to 20 per minute. Remember this. So this is decreased frequency of blinking. So if these are the lid signs, let's have a look. Which one is Cocker's in this? Right eye or left eye? Of course, it is this eye where there is a staring look. This is your Cocker's sign. And what should I say in this case? This is Dalrymple. This is just not covering 2 millimeters of upper limbus. So it's a lid retraction. If it is a lid retraction, we call it Dalrymple sign, right? So we are seeing two signs in the same patient, one in one eye, one in another eye. So once you know this, we come to another important thing is, how do you manage the lid signs? So how do you manage the lid signs? Let's write here. We, of course, what was the cause? The cause was overaction of LPS. What did you learn with me? When there is an overaction acting muscle, क्या करते हैं हम लोग? Recession. Okay. So the treatment would be, क्या treatment होगा? We will say it is recession of LPS. It is recession of LPS. Right? ठीक है? So that was about your treatment. And of course, if you have to give any medical treatment, just know this one also, that we can go for, especially in case of oversympathetic activity and all, we can go for guanethidine eye drops. It depletes the sympathetic storage sites. That is the main mechanism of guanethidine eye drops. Okay. Once it was asked, now it's not recently being asked, but you should know it, isn't it? So before I go further, we should also know what is no specs. So that's another way of learning the different clinical features of thyroid eye disease, and that is no specs. What is no specs? We all know. N stands for there's no sign. O is only lid retraction, only lid signs or lid retraction. Then soft tissue involvement. After this will come the proptosis. Then the extraocular muscle involvement. What is Mobius sign? Mobius sign is when there is weakness in convergence. Then comes your corneal involvement. Why corneal involvement? Lid signs, there is exposure keratopathy. This is the main complication. Please let us note it down. Corneal involvement will be exposure keratopathy. Hope you understand this, right? Yeah. And of course, sight loss becomes S due to optic neuropathy. So, we have quickly learned like this that when you are talking about proptosis and optic nerve involvement, how do you manage it? We talked about seismic steroids, immunosuppressives, radiotherapy or decompression surgery. Lid signs, lid surgery, squint muscle myopathy, we have to go for squint surgery. Okay. And of course, managing the soft tissue signs, symptomatic management with adrenaline eye drops or acetylcysteine eye drops. Right. Now, suppose you have a patient where all these 3 surgeries are required. Which one should you do first? Decompression, squint and lid. So, please learn the sequence. It is diesel. So, we are going to learn this first decompression diesel, that is first decompression, then squint surgery and then lid surgery. So, why the sequence is important? This is the sequence in sequence order in which you should do. Why? Common sense. Any decompression surgery, position of eyeball is varying, so amount of squint will vary. When you do a squint surgery, the lid position will vary. That's why we have to do this way. Another lastly, what we have to know in this topic is, what is Rundle curve? Now, this is again an additional information. Let's draw. When we are actually tracing the severity of the disease, you can do it with, if this is the time factor, with time what happens to severity of thyroid eye disease. So, what we see is there is one dynamic phase where it keeps increasing and then it becomes static. This is what is called, this is a dynamic phase and then it becomes a static phase. Hope you are drawing it, guys. So, this is what is called Rundle curve. I know this is an extra point. It has not been asked in your exams yet, but of course, as I told you, little bit extra points are important. Anytime it can be asked, right? So, it is mainly to analyze the severity and progression of the thyroid eye disease. We have just made this diagram. That was about thyroid eye disease. We next talk about is orbital cellulitis. Hope you are writing. It is inflammation behind the orbital septum. Okay? Okay. Now, we talk about is, before moving further, let's make this concept clear. What is orbital septum? Where is this? Chalo. If this is the lid, main lid is formed by tarsal plate. This is your supraorbital margin. Wherever this lid is ending and this is the bony margin, there is a space. Okay. So, if this is your supraorbital space like this and this is the lid with the tarsal plate and this is your lid margin. This is the eyelash. So, this space is filled by a thin connective tissue and this is what is called orbital septum. Got it now? So, this is acting almost like a wall of the orbit. Similarly, if you want to draw, you can draw below. This is your inferior lid, tarsal plate with the lid margin, right? And if this is your bony, inferior orbital bony margin, and this becomes your orbital septum on the lower side. Okay? So, this is what is orbital septum. Now, pay attention. Whenever there is any inflammation in front of the septum, just say for example, any insect bite around the lid, on the eyes. So, it is not very serious. Of course, the swelling is very serious because it is all loose tissue and whatever swelling happens around the eye, it always looks too much. बहुत ज़्यादा swelling होती है, right? Why? Because of all the loose skin. This is the reason. But it is not serious because it is not involving the orbit and therefore, it won't lead into very serious complications. This is called, when it is in front, we call it preseptal cellulitis. So, let us learn like this. Orbital cellulitis, if the inflammation is in front, we call it preseptal cellulitis. And when the inflammation is behind, now you call it orbital cellulitis. When it is behind, we call it orbital cellulitis. So, what can be the causes or etiology of orbital cellulitis? What can be the cause, why this is happening? Of course, preseptal I told you, commonly it is insect bite, any trauma, that is preseptal. But later, when you talk about orbital, main causes, number 1 as in front of you is sinusitis. There is an exam question, which sinusitis is more common to lead to orbital cellulitis? Think yourself, ethmoid sinus ki wall, which is cribriform plate, isn't it? So, you will answer ethmoid sinusitis. That is the main most common sinusitis to lead to orbital cellulitis. Make a Q there, all of you. Of course, then there can be a dental cause, number 2. It could be dental cause. There could be lacrimal sac of inflammation and infection, that is dacryocystitis. So, everything around this area. Then endogenous cause if there is any septicemia, or exogenous cause means again trauma or surgery, right. So, these are the different causes for orbital cellulitis. How will the patient present? Before I go to the how it presents and clinical features, we can also discuss the etiological agents, the most common bacterial infections which are leading orbital cellulitis. It applies to both preceptal also and orbital cellulitis. So, most common you will answer of course is Staph aureus only, then Streptococcus pyogenes, and Haemophilus is more common in children, right. Fungal, of course, most common fungus involving the orbit. I think I have discussed this earlier chapters as well. We answer mucormycosis. Okay, most common fungal infection or most common fungal cause of orbital cellulitis is exam question. We will answer mucormycosis. So, these were the causes and etiological agents. We next talk about how this patient will present. So, let us have a look here. This is a patient with orbital cellulitis in her left eye. So, how does it present? As you can see, the eye is proptose. It has to be a painless proptosis. More commonly, it is, so lie down, give the heading clinical features and learn with me like this. First of all, more commonly it is unilateral and presenting with unilateral painful proptosis. Okay. Unilateral, I told you how to classify proptosis. According to that, it is unilateral painful proptosis, number 1, right. Of course, then number 2 we can learn because of this proptosis there is restriction of eye movements. So, the restriction is not due to nerve involvement, it is due to proptosis. Okay. So, restriction of eye movements is due to proptosis. We next talk about, please remember it is due to proptosis, not 3, 4, 6 are fine and it is not the involvement of 3, 4, 6. It is due to proptosis that you are getting the restriction. Next we talk about the third point. Third point of course is the patient will present with, of course, can you see all redness around, you will see conjunctival congestion also and lid edema and lid redness and all that features, all these soft tissue signs. And lastly what you get is fever and malaise, you get systemic features like fever and malaise. This is how an orbital cellulitis will present, right. So, have a look. So, it is a unilateral painful proptosis, restricted eye movement. This will be due to proptosis. We can note it down here. And of course, because of this, slowly when it is the orbital apex that is involved, then you get decreased visual acuity. Only when optic nerve involvement has to be there, then you will get decreased visual acuity. So, when the orbital apex is involved, then the vision is affected. And of course, I talked about conjunctival congestion, lid edema and fever and malaise, right. Revised again. Okay? This is how the patient presents. When you talk about how to manage it, of course, investigations, as I told you, we will go for either CT or MRI to see the orbit, right. And very important question here before I move further, it is considered an ocular emergency. So, orbital cellulitis is considered as an ocular emergency. The question is why? Because of risk of cavernous sinus thrombosis. This is actually a double Q guys, so please be very, very alert here. So, this is considered, so if this patient, this lady, I should admit her immediately. Why? Generally admissions are not that common in eye pathologies, but here I am going to admit her because I have to actually see that it does not spread to the cavernous sinus thrombosis. So, I admit the patient as one modality of treatment. First admit the patient, start with IV antibiotics and start with IV anti-inflammatories. IV antibiotics and IV anti-inflammatories. This is what you will do, right. Prognosis is still better compared to cavernous sinus thrombosis. So, this is admitting the patient starting with IV antibiotics. Please keep in mind we have to cover both aerobic and anaerobic coverage has to be given. Both aerobic and anaerobic coverage has to be given. What antibiotics I can give here is I can go for ceftazidime, vancomycin or metronidazole for anaerobic coverage. Okay, so that was the treatment that we are going to give to this patient. And of course, apart from cavernous sinus thrombosis, what can be the other complication you have to keep in mind? Okay, so if you keep in mind the grading, of first it is, or mainly it is preceptor cellulitis, then it becomes orbital cellulitis, right? That the grouping, that Chandler's grouping that we learn, and then after this subperiosteal abscess, and later it involves the cavernous sinuses. So we won't forget, because I think there was one recent question here, so we will remember about subperiosteal abscess, and then of course it can later lead to cavernous sinus thrombosis. So this is how you are going to treat this patient, right? And as I just told you, you will immediately admit this patient, start with IV antibiotics and anti-inflammatories to prevent cavernous sinus. See that cavernous sinuses are not involved, right? So, but what about if this patient has already got the involvement of cavernous sinus? I should be knowing this, na? Because I have to prognosticate this patient. So, what should we do here? How should I check that? Just go back to your anatomy. Cavernous sinuses, when these are involved, it involves 3, 4, 6, 5, 6, all these nerves are involved, isn't it? So, which is the first nerve to be involved? First sign of cavernous sinus thrombosis, we are going to take that away after this topic. It is the 6th nerve which is involved first. So, in this patient, I should check the abduction. 6th nerve supplies the lateral rectus. Everybody remembers LR6, SO4. So, here what we should do is check the abduction of the other eye. Why I am not saying of the same eye? When 6th nerve involvement, cavernous sinus involvement is always bilateral, right? So, same eye I am not saying, because this restriction is already there due to proptosis. How will I know it is involved or not? I should check the abduction of other eye. So, in my clinical examination, I will check the abduction of other eye. If this other eye is fine, then I know that cavernous sinuses have not been involved yet, because that is the first sign of involvement. Okay? So, this is very important and you should keep this in mind. Now, next discussion has to be, we need to talk a little bit about fungal orbital cellulitis. So, what do you call that? ROCM, that is rhino-orbital cerebral mucormycosis. Give the heading. ROCM is rhino-orbital cerebral mucormycosis. So, these are the structures which the mucor is involving, right? So, this is mainly first important point, of course, the infection, it is due to inhalation. We all are inhaling these spores, but we are not getting infected. Inhalation of spores is one thing, but why this patient is getting infected? Because he is immunocompromised. So, if the patient is a case of immunocompromised patients, then what happens? This is going to lead to infection by either Rhizopus or mucor. More commonly, so the agent, etiological agent we will learn here is Rhizopus, or it could be mucor. More commonly it is Rhizopus. Okay? So, this is important. Once we are talking about how this infection is taking place, what is the etiological agent, another very important point here is this mucor or Rhizopus. The nature of this organism is it is angioinvasive. So, what happens when it is angioinvasive? When it invades the blood vessels, it is causing ischemia in the tissue. And when it causes ischemia in the tissue, this is going to lead to necrosis. And this necrosis is the cause of black eschar that you see. So, actually it is not black fungus, it is mainly necrosis of the tissue. This has to be kept in mind. Okay? So, in this patient, what do you see? This is your infection by mucormycosis. This is a case of ROCM. So, this is a case of ROCM. Okay? So, again, it is not black fungus, it is a necrosis of the tissue which looks black, right? And I think everybody is aware that after this COVID, when a lot of steroids were being taken in, leading to immunocompromised situation, and that led to this infection very rampant and very common, right? Lot of tragedies have happened due to ROCM. I have already mentioned you the complications of orbital cellulitis. One more that we will add, which is specifically for ROCM, is it can lead to central retinal artery occlusion or central retinal vein occlusion. So, one serious complication in addition to the ones that of course involving cavernous sinuses or subperiosteal abscess. What is important for ROCM is it can cause CRAO or CRVO. Just keep this in mind, right? How will you manage it? So, how do we manage it? We go for intravenous antifungals, and which one will you give here? We go for amphotericin B, which is considered very effective, otherwise posaconazole. So, amphotericin B you have learned with me in endophthalmitis. If it is a fungal cause, we can go for intravitreal injections as well, right? But here of course IV amphotericin B or posaconazole. Okay, so next we talk about cavernous sinus thrombosis. So, cavernous sinus thrombosis, making again life simple for you all. Let's make a simple, very simple diagram here. If these are the two sinuses, what are the nerves which are passing along the walls? We will learn it as 3, 4, 5. 5 cuff 1 and 2, but this is 3, 4 and 2 branches of 5. And what about the 6th nerve? Why it is the first nerve to be involved? Because it is passing through the body of the sinus. This was asked in the exam. So, I am repeating. First sinus, 6th nerve involvement. Why 6th nerve? Because it is passing through body of the sinus along with internal carotid artery. This is the internal carotid artery, right? So, what are the clinical features? The first sign is asked is 6th nerve palsy. Think with me, what else? Okay, so when you say 6th nerve palsy, that is the first nerve. Later on, all 3, 4 and 6 will be involved. So, the next clinical feature would be this time again restriction of ocular movements as we have learned, but this time it is due to involvement of 3, 4 and 6. Keep thinking and learning with me. Okay, so total restriction of eye movements and ophthalmoplegia here is due to the involvement of all these 3 motor nerves, 3, 4 and 6, right. Okay, then we come to the next is number 3. What next? 3. Talk about oculomotor. So, oculomotor is an efferent for accommodation, efferent for light reflex, isn't it? So, we will say absent light reflex and absent accommodation reflex. And even the blink reflex is absent because the 5th is gone, therefore, absent corneal or blink reflex, right. And there will of course be bilateral painful proptosis. So, there is bilateral painful proptosis. I want you to learn this way thinking along with me. This will be more helpful. Why it is bilateral? Just will be showing you the slide again. And then of course, there can be bilateral papilledema and later write down mastoid tenderness. So, when you say mastoid tenderness, where is your mastoid bone? Behind the ear. Why there is tenderness? Because the amizary veins here is a tributary of cavernous sinus. Okay? Because the amizary veins of the mastoid are tributary of the cavernous sinus. We can go ahead mastoid. This is a very good indication that okay, there is a cavernous sinus involved. So, don't all of you keep pressing very hard and say no, there is a tenderness. It's not. Okay? So, this is your cavernous sinus thrombosis. Let's have a look here. So, this is the slide which should never be forgotten. So, where is the pituitary gland? Where is the optic chiasma? And these are the signs. And can you look at the sinus and see that these cavernous sinuses are connected to each other? This is the reason if you always get a bilateral involvement. Okay? And of course, these are the different nerves 3, 4 and 5. And this is the 6th nerve along with internal carotid artery. This is the sphenoid sinus at the bone. This is a case of cavernous sinus thrombosis. Can you see the severe bilateral painful proptosis, chemosis, congestion, everything is there. Of course, we didn't mention there. You can please note down in the clinical features. We are going to get severe chemosis and conjunctival congestion. Just as in orbital cellulitis you have learned, this is even more severe. Talking about the treatment, of course, is same as in orbital cellulitis. We go for intravenous antibiotics and anti-inflammatories. Okay, both aerobic and anaerobic coverage has to be given. And of course, prognosis is not that good. We will keep this in mind. Right? Prognosis is poor. So, next we talk about is superior orbital fissure syndrome. So, when you say superior orbital fissure syndrome, what is the other name? Not very commonly used, लेकिन आपको पता होना चाहिए. This is Roshan-Duvignaud syndrome. So, 3, 4, 6 are involved. What you are going to get here? is ophthalmoplegia. Of course, any problem at the orbital apex will protrude the eyeball, push the eyeball out, leading to proptosis. And the nasociliary nerve, which is a sensory supply to the cornea, this is going to lead to, so branch of nasociliary is long ciliary nerves, that is supplying to corneal, leading to sensory corneal sensation, responsible for corneal sensation. Therefore, what you get is loss of corneal sensation. Easy to learn? Great. Now, there's one term called orbital apex syndrome. What is that? When, go back to your diagram. What did you make in the diagram? This was the diagram, if you remember, right? This was it. What was this? Our optic foramen with optic nerve and ophthalmic artery. You remember this? So, any pathology in the superior orbital fissure, this can be involved. So, if there is optic foramen involvement, optic nerve will be involved. So, all the features of superior orbital fissure syndrome with optic nerve involvement is called orbital apex syndrome. Clear? This is what is orbital apex syndrome. Easy? Take care. Next, we will talk what is Tolosa-Hunt syndrome. Tolosa-Hunt definition is what they have asked you, granulomatous inflammation of cavernous sinuses, and of course, it can involve the orbital fissures, superior orbital fissure and orbital optic foramen or the orbital apex area, right. So, but mainly it is the cavernous sinus, SOF and orbital apex, that means foramen can be involved, but mainly cavernous sinus. So, this is what is called Tolosa-Hunt syndrome. Of course, it is rare, keep that in mind. Clinical features, periorbital and hemicranial pain is seen, number 1. Along with that, of course, all the nerves are involved, so you are getting diplopia, but proptosis is not that severe, it is mild. Okay? You get lot of periorbital pain, that can be severe, proptosis seen as little mild, and of course, pupillary. So, you don't have to actually learn this, think what were the nerves involvement, what are the nerves involved, you will answer everything. Whenever these nerves are involved, there has to be diplopia, the patient is complaining of some double vision, the patient is complaining of lot of pain, and there is mild proptosis. Of course, we are going to confirm through CT and MRI. Okay? So, we confirm it with CT and MRI, and what is the main treatment that you go for Tolosa-Hunt? It is granulomatous inflammation, we go for systemic steroids, number 1, and second can be immunosuppressive drugs. So, the treatment would be in all these cases systemic steroids and immunosuppressive drugs. Okay, so the next heading, please give the heading lacrimal gland tumor. So, when you talk about lacrimal, where is the lacrimal gland? Over the superolateral part of your orbit, isn't it? There are two parts of lacrimal gland, palpebral part and orbital part. So, when you say like mainly just learn the tumor is from the orbital part. So, more commonly from orbital part. That is one important thing. And what will it cause? Non-axial proptosis, because any tumor here is going to push the eye down and in. So, it leads to non-axial proptosis. So, non-axial or dystopia is mainly down, where it is, batao? Downward and nasally. So, you will say the eye is pushed downward and nasally. Okay, keep thinking with me. Sometimes you can get some swelling on the superolateral part of the lid, right. This part is all swollen. Of course, that is the location of the lacrimal gland, you can get it. And typically, it is described as it is non-tender swelling which is firm. When you palpate, it is a firm and a non-tender swelling. Right? Now, what they ask you in the exam, apart from that there is a dystopia and downwards and nasally, important thing is types of tumors, what are the names, what are the more common, what are the tumors, which is the most common benign, most common malignant. These are your exam questions. So, let us come to that. So, if you talk about, okay, don't just get intimidated with this chart. I would like you to focus on epithelial tumors because that has been asked. Epithelial tumors may सबसे important, or overall if they just ask you this question, most common type of lacrimal gland tumor, we will answer benign. Pleomorphic adenoma or benign mixed tumor. So, this is the most common lacrimal gland tumor overall. Whenever they ask you this way, and if they ask you most common malignancy, so my message here is unless and until the question is telling you non-epithelial, we are not entertaining this part. we will simply be talking about most common benign mixed tumor, most common malignancy kaun si hai? Adenoid cystic. Adenoid cystic is the most common malignancy of lacrimal gland. What are the three malignant tumors? Pleomorphic adenoma becomes pleomorphic adenocarcinoma, mucoepidermoid and adenoid cystic. There is another question, which is the most dangerous of all these three names 1, 2 and 3? Again it is adenoid cystic which is most dangerous. Why? Because there is perineural invasion, and because of the perineural invasion it actually spreads very fast. So, perineural invasion, it spreads very fast. Okay? This is the reason that you have to keep in mind regarding the questions they ask you. And now if the question says non-epithelial, then the most common becomes your lymphoma if we are talking about non-epithelial, if the word is given there, okay, and benign is inflammation. Main part, these are the questions that you have to answer this way. Okay, how will you manage it? Never do incisional biopsy, we always go for excisional biopsy. So, let us note down, treatment here will be excisional biopsy. Never go for incisional biopsy. This is an important information you have to keep in mind. So, have a look, this is your lacrimal gland tumor, right. In this location, this is your lacrimal gland tumor. In this patient, again this part there is a, which eye? Can you see this? This eye looks a little, this eye is central, right. This is more central, but this eye is going down and in, right. And there is a fullness out here. This is mainly your lacrimal gland tumor. Next we talk about is, what about just 1 or 2 lines regarding lacrimal sac tumor. So, it is again a common sense, sac is on the nose here, right. So, any tumor here means the eye is going to go superotemporal. So, when you talk about lacrimal sac tumor, as you can see, the eye is going to go up, and as I just said, what did I say? It will go superotemporal. So, there is a superotemporal dystopia, right. This is one point we will remember, and then they can ask you the name. Again remember, the name is benign, malignant. In malignant, most common is squamous cell carcinoma, and benign mein it is papilloma. Okay. So, this is what we are going to learn about lacrimal sac tumor. Okay. Next, give the heading pulsating proptosis. So, do you all know what is pulsating proptosis? The proptosed eye is showing pulsations. So, we have to think what can be the causes. One and the most important cause is, so let us give the heading pulsating proptosis. Most important and most common, which is asked in the exam, we will learn CC fistula, keratico-cavernous fistula. And what can be the other causes? Think like this, if the roof is defective, then the intracerebral pulsations are transmitted to your eye. So, fracture roof, number 2, and number 3 we will learn here. So, this one is most common. Then second, fracture roof, and number 3, when the roof is not formed and it is defective, that is NF1. So, here we will note down that the intracerebral pulsations are transmitted to the eye. Right. So, this is about causes of pulsating proptosis. Now, before I go to the next one, that is intermittent. Okay, what is intermittent? I hope you understand. Intermittent means, see, in pulsating, the proptosis is constant, but there is pulsations. Intermittent means sometimes the eye is normal, sometimes it is proptosed. Right? We will just come back to this. First, let me cover what is keratico-cavernous fistula. You just saw the diagram in the slide of the cavernous sinuses, how the internal carotid artery is passing through it. Any fistula between these two is called CC fistula, and it is a direct one, right. So, you can divide it actually CC fistula as direct or indirect. When you say direct, we are talking about there is a direct communication between internal carotid artery and cavernous sinus. When you say indirect, it is mainly the meningeal branches, okay, of internal and external carotid artery with the cavernous sinus. These are called dural shunts. We call them dural shunts. Okay? And more than 75% of the direct cases are due to trauma. The main cause is trauma. Right? So, when you talk about the direct fistula, what you have to know is a triad. The triad is this patient will complain of pulsating proptosis, there will be chemosis and whooshing sound in the head. Right? So, keep this in mind, there is pulsating proptosis, there is chemosis and whooshing sound in the head. This is the triad of a direct CC fistula. And now think with me. If there is a fistula in the cavernous sinus, the pressure in the cavernous sinus is increasing, right? So, if the pressure in the cavernous sinus is increasing, what all effects it is causing? Let's learn together. If the pressure is increasing, it is increasing, the number one thing that is happening is increased episcleral venous pressure. You all remember how I taught you the drainage of the aqueous going and reabsorbed in the episcleral venous system? So, when the episcleral venous pressure is more, this drainage will be less, and that is going to lead to glaucoma, number one. Number two, what happens is when there is a more pressure, there is venous stasis, which later is going to lead to arterial stasis. This causes ischemia in the anterior segment and venous stasis retinopathy. It is venous stasis retinopathy. So, there are changes in the retina and there can be anterior segment ischemia. You think and learn, it becomes easy. So, more pressure, more episcleral venous pressure, glaucoma. More venous pressure is causing venous stasis retinopathy and anterior segment ischemias. Then we talk about that because of all this, when there is a decreased blood supply to the nerves that are passing through the cavernous sinus, naturally there will be involvement of 3, 4 and 6 and functions are affected. And lastly, what is also happening is sometimes the sympathetic chain is also passing along the internal carotid. This is affected, leading to postganglionic Horner syndrome. We all know that Horner syndrome is lesion of the sympathetic chain. Okay? So, these are the things that are happening, and because of all this increased venous pressure and stasis, there is congestion in the conjunctival blood vessels. We just need to know it because it has a very typical name, corkscrew vessels. It is asked. It is again can be seen in both type, direct and indirect. Just remember, in an indirect type, all the features are in lesser intensity compared to the direct type. That's what you have to know. Okay, so this is a case of your CC fistula. Look at the severe chemosis here, right? As you can see with the pulsating proptosis and severe chemosis. Pulsating proptosis, of course, we are not able to understand until we are seeing the patient. One more interesting thing, if it is due to CC fistula, this pulsating proptosis may be associated with a brew and a thrill as well. Okay? Yeah. And now look at this. This is what are corkscrew blood vessels. Okay? So, this is again important, they asked in the exam. When you are doing an investigation, you can do a CT MRI, and what do you see mainly is dilatation of superior ophthalmic vein. Just remember, dilatation of superior ophthalmic vein. Okay, talking about the treatment part. Generally, the indirect one resolves spontaneously by its own. Otherwise, when you talk about direct one, what can we do? We can go for balloon tamponade number 1, or we can go for coil embolization. Okay? Just remember these 2 points. Okay, so now we were talking about, next was intermittent proptosis. So, I have just explained you intermittent means. Intermittent means that the patient is saying that, okay, suppose the patient comes to you and says, ki bhai, I feel normal like this when I am lying supine, but when I turn to one side, I feel my eyes coming out. So, that is change of head posture, Valsalva maneuver, or any coughing. All these he feels eyes coming out. This is all intermittent proptosis. So, common sense, the only cause that we have to learn at our level is varicose veins in the orbit, that is orbital varices. Okay? Right, all of you? So, the only cause, so now you know what is intermittent proptosis. We have to know it changes with head posture, right? Or you can say Valsalva procedure, coughing and so on. So, these are low flow veins and which are responsible. So, just remember these are the orbital varices, varicose veins in the orbit, orbital varices. And this has been your exam question, that the cause of, what is the cause of intermittent proptosis, and the answer is orbital varices. Will not forget this. Okay? Right. So, when you are going for the imaging and investigation, we see the pre-contrast image here. This is in the resting stage. This is the main growth that you are seeing here. These are, as I told you, distensible. These are thin walled veins. These are mainly low flow veins. And when you are putting contrast and mainly doing a Valsalva, this is what you see here, right? So, very, very clear. This is what is orbital varices. One more thing, sometimes what happens, there can be calcification here and this can lead to stone formation. We call it phlebolith. So, any stone formation due to calcification, So, it can be associated with the stone that is called phlebolith, right. So, talking about the treatment for these orbital varices. So, surgical excision is a very, very difficult thing. It is very friable, difficult to excise. So, we can note it down. This modality is quite difficult because it is very, very friable. So, what we generally opt for, either we go for carbon dioxide laser ablation or endovascular embolization, right. Of course, this will become the last option, that is surgical excision. Before moving further, let us discuss a few very, very important questions that are being asked in your exam. We are going to put double Q here. These are all important exam questions. So, let us see most common primary intraocular malignancy, intraocular, right. For children, what do you answer? Retinoblastoma. For adults, it is choroidal malignant melanoma, right. And if this option is not given, then the next best option is metastasis. Coming to the next one. Most common in this type, intraorbital primary malignant tumor. In case of children, yes, we answer rhabdomyosarcoma. And for adults, actually these were questions of two different exams. In one, they had just asked you about which lymphoma. It is not non-Hodgkin's lymphoma. Then which cell type? We will answer B cell type. Okay? So, it is B cell type. Come to benign. So, there was another question, most common intraorbital benign tumor. So, in intraorbital benign, for children, we have to learn capillary hemangioma. This time is more important. Earlier, we used to answer dermoid cyst, but now the latest edition says first answer capillary hemangioma. Second option can be dermoid cyst. And what about the adults? For adults, this has been a very important question, cavernous hemangioma. All of you, cavernous hemangioma, right. Now, this reminds me of another question. They have also asked you what is the most common source of metastasis? Source of metastasis in orbit. This was also asked. So, for females, we are going to answer breasts, and for males, we will answer lungs, right. So, these are your very, very important exam questions. Now, let us next give the heading cavernous hemangioma. We will give the heading cavernous hemangioma. What are the points to remember? We just learned this is the most common intraorbital, suppose they ask you like this, most common intraorbital tumor of adults. If the word malignant is not mentioned, we presume we are talking about benign. Please remember this. So, the question was most common intraorbital tumor of adults. Our answer would be cavernous hemangioma. So, that is number 1. First question, okay, we will quickly note down. First question was most common intraorbital tumor of adults. Coming to some other important points that we have to learn. So, we make a diagram. If this is the orbit, the eyeball, optic disc, optic nerve, right. So, we all know about the intraconal space, right. So, this tumor is located in the intraconal space, and therefore, so it is location is intraconal location. So, there were many options and all are correct except This way also the question has been asked. So you have to know all these points about cavernous hemangioma, that it is intraconal in location, and though we all know that hemangiomas are so difficult to resect, this one is encapsulated and therefore it is easily resected. Encapsulated, so easily resected. Important points, and because it is just behind the eyeball in the intraconal space, it leads to axial proptosis. Axial proptosis. And how are you going to manage it? We will treat it with, we will excise it bilateral orbitotomy. So, excision bilateral orbitotomy. These are some important things we have to remember. Let's have a look. So, as you can see here, so this is a case where in this patient, in the left eye, so it's already marked with the green here, that this is the main pathological eye. So, this side you can see the pathology where there is mild axial proptosis, and very important, there is fullness in the infraorbital part, right. So, there is fullness in infraorbital part. And yes, this is your cavernous hemangioma, this is your well circumscribed, encapsulated and intraconal in location. This is cavernous hemangioma. So, that was about cavernous hemangioma. We next talk about what is this. This is most common intraorbital malignant tumor of children. We just learned about this. This is your rhabdomyosarcoma, right. So, what are the points we will remember? This disease is generally more common in less than 16 years of age in children, and of course, the important exam question has been covered. Most common intraorbital malignancy, right. This is done. Yeah. Another important thing that we will keep in mind, that these cells, these rhabdomyosarcoma, the tumor cells, they are mainly the tumor arising from, they are the tumor cells from connective tissue. Okay. So, this is mainly tumor of connective tissue. Which actually has the capability of differentiating into muscle cells. So, just remember, this has a capability of differentiating into muscle cells. Right. Next thing that you have to know about rhabdomyosarcoma very quickly, the names of the 4 pathological types, what are those? And secondly, keep in mind, we generally rely on chemo and radiotherapy for treating rhabdomyosarcoma. We avoid any surgical excision. These are the 2 main points you will remember. Okay, let's note it down. So, talking about what are the different types of this pathological types, it can either be embryonal, number 1, this is most common, but it is undifferentiated. So, that is not good, right. Undifferentiated always has a poor prognosis. One is embryonal, second is alveolar, this is also very aggressive, pleomorphic and boteroid. Just remember these 4 names. Okay. Talking about treatment. So, as I said, the treatment is going to be either we go for number 1, focus on chemotherapy, it is very responsive, and which drugs we can give in chemo? It is vincristine or actinomycin D. And second, it is radiotherapy. So, this is a very radio-sensitive tumor and we get quite good results with radiotherapy. So, generally it is combined with chemo, right. So, surgery is generally avoided, exentration is not done. Any tumor and malignancy, exentration we'll talk about what is evisceration, enucleation and exentration at the end of this chapter. Next, what was dermoid cyst? Second most common benign intraorbital tumor in children. Yes, that is your dermoid cyst. We all know dermoid cyst is nothing but a choristoma. What is a choristoma? Means normal tissue at abnormal place. So, this is a choristoma and you generally find it along embryonic sutures, isn't it? So, this you know more in detail than I do. So, embryonic fissure ke along milega, right, and it is mainly the sequestration of embryonic epithelial cells. It is nothing but sequestration of embryonic epithelial cells. and very typical. You can see a hair coming out of the swelling. We know this is mainly dermoid. And coming to important point, most common site is superotemporal, okay, along the frontozygomatic suture. Superotemporal, that is along the frontozygomatic suture. And when you are removing it, it has to be always taken in mind, and it should be, we have to be very careful that we don't spill it, right? Because the keratin will come out and will cause lot of inflammation. So, treatment is just excision in toto. Excision should be in toto. And of course, when you do the CT scan, you are seeing a well-defined lesion. I just missed the investigation, we will do a CT scan. So, we see a well-defined lesion, and of course, excision has to be seen that it does not spill, because it will lead to a lot of inflammation. So, it should be excised in toto. Okay, so this is what is dermoid cyst. As you see in this child, this is a dermoid cyst. It is intravital, right? And which is the most common benign intravital tumor which we are learning in the children? It is capillary hemangioma. Can you see this? This is what is capillary hemangioma. So, that is one question. We have just solved it already. You have to know another important things. What are other points are that it mainly consists of ill-defined anastomosing channels. Ill-defined anastomosing channels. Another important point which differentiates it from Sturge-Weber syndrome as well, that is it blanches, it will blanch. Right, and as you can see, it is pushing the eye down and in, leading to non-axial proptosis, dystopia. It is dystopia or non-axial proptosis. When you talk about its treatment part, again so difficult to excise this capillary hemangioma. It will bleed, it is not that well defined, right? It is not well defined like cavernous hemangioma or talking about dermoid cyst. So, this is a challenge. How do you treat it? We should know one medical treatment, that is propanol. So, one is propanol, we can give oral. Otherwise, intralesional triamcinolone acetate. We go for triamcinolone acetate. And third, we can go for is, if we have to remove surgically, it is very, very difficult. We go for carbon dioxide laser resection. You can go for carbon dioxide laser resection, right? So, this was about the treatment of capillary hemangioma. Okay, what next? How is it different from Sturge-Weber syndrome? What is Sturge-Weber syndrome? So, look at this one, this child, this also has a he has a capillary hemangioma on the face. What is this called? This is called nevus flammeus, isn't it? This is your nevus flammeus. It does not blanch. So, that is one. So, what is Sturge-Weber? Sturge-Weber syndrome is nothing but a phacomatosis. It is a phacomatosis. What is the triad? Let us learn the triad here. Three things. So, to triad, they have asked you. What is the triad of Sturge-Weber? Very simple. We will learn like this: capillary hemangioma on face, then capillary hemangioma in brain, and glaucoma. This glaucoma is due to increased episcleral pressures. Right? So, we will keep this in mind. This is what is Sturge-Weber syndrome. We next talk about is optic nerve tumors. So, two main important conditions that we have to learn is meningiomas and gliomas. So, optic nerve sheath meningioma and optic nerve glioma. Let us learn one by one, but before that, very quickly, if I am tempted to make a line here and very quickly we learn a few points together, and then we can take one by one. This is going to help us to learn things fast. क्या? Meningioma. Meningioma is more common in middle-aged females, okay, whereas this is more common in female children. Gliomas is a disease of female children. Take optic nerve meningiomas are associated with NF2 and gliomas are associated with NF1. Optic nerve gliomas are mainly pathologically typical feature is psammoma bodies, whereas here we are going to learn one by one again. This is just a quick help to you all. Secondly, here it is most common is pilocytic astrocytomas. It is from the astrocytes. So, astrocytoma, and meningiomas are from meningoepithelial cells, right? Then, is there any other interesting? Yes, one more. Just think this way, you will learn everything. So, any optic nerve tumor, naturally it is first going to cause symptoms of decreased vision, difficulty, all the signs of optic nerve disease, and it is only when this tumor is more in size, it pushes the eye out, leading to proptosis. So, that is common in both, that proptosis is a late feature, right, in both the cases. Another interesting difference that you can learn here is CT scan findings. In meningioma, it is a tubular enlargement, okay, it is tubular enlargement. And in glioma, it is a fusiform enlargement. Of the optic nerve, right? So, that was just a quick help. We will take one by one. So, first give the heading optic nerve sheath meningioma. Of course, as I told you, number 1 point, it is common in middle-aged females associated with NF2 patients. And how does it present? And these are what exactly? From meningo, right down. These are arising from meningoepithelial cells, okay, write down meningoepithelial cells, primarily from arachnoid layer. Right. Another very important thing is that primary tumor is less in incidence. More than 2/3 of these meningiomas are extension of intracranial meningiomas. Okay? So, more than 2/3 are nothing but secondary tumors. They are more than 2/3 of these cases are actually 2/3 samajh lo, why to create a confusion of more than. So, 2/3 of cases are extension from intracranial meningiomas. Okay. Then we talk about the triad. What is the finding? So, initially as I said, the nerve is involved. So, what is this Hyod-Spencer triad? Even if you don't want to learn the name, nobody will ask you. But the triad, you should know that initially there has to be optic nerve problem leading to progressive vision loss, later atrophy. And there is one typical finding we will learn, opticociliary shunts. Okay? So, this is the triad, and later what will happen? So, to understand this, as I explained, if this is the tumor arising from the optic nerve, right? So, any tumor arising from optic nerve will first initially manifest as all the 5 signs of optic nerve disease, and it is only later when this tumor size is increasing in size, it pushes the eye out, leading to proptosis. Make the diagram please. So, proptosis is always a late feature. We have to keep this in mind, right? Okay. So, this is what late features may. There is proptosis and there can be restricted up gaze. Now, why is that happening? We have learned this together, that if you look at the extraocular muscles, again make the diagram please. It is the superior rectus muscle which is starting from the orbital apex from annulus of Zinn. It is inserted on the eyeball like this. Okay. And when it is inserted like this, it's a normal anatomy that some fibers of this superior rectus is attached to the myelin sheath of the optic nerve. Now, this is normal anatomy. So, whenever what is happening? Now, what is happening? We are saying there is a tumor out here, isn't it? This leads to affecting this attachment or so, and therefore, there is restricted up gaze. And if there is a restricted up gaze, the patient tries to move his eye up. Sometimes what happens, there can be gaze evoked amaurosis fugax. Because of this, what is amaurosis fugax? Transient loss of vision. There is some pressure and pull on the optic nerve due to this up gaze, leading to gaze evoked amaurosis fugax. This is one extra point, not asked in your exam at your level about this, but it's an interesting point, not very difficult to understand, right? Okay. So these are the late features of meningioma. That was the clinical features. We know what is it, kahan se aata hai, what it arises from what place, and common in which patients, and what are the presentation. Now, when we are writing these late features, we should not miss to write one more here, and that is your fullness in the temporal fossa due to hyperostosis of the hyperostosis of the sphenoid bone, right? So, because of the hyperostosis of sphenoid bone, we get fullness in temporal fossa. So, you may get this, right? So, these are some of the features we are going to keep in mind. Talking about the pathology, yes, what are psammoma bodies? So, these are laminated calcified structures. Just remember like this. These are laminated calcified structures which are called psammoma bodies. And have a look, what is this? This is what is opticociliary shunts. What is it exactly? Anastomosing blood vessels between the ciliary system and the central retinal artery system, right? So, these are already present, only what happens in this condition, they open up. That is called opticociliary shunts. You can see it on the, so generally in meningiomas, in central retinal vein occlusions also you can sometimes see. So, this is between your ciliary system, generally short posterior ciliary artery and central retinal artery. These are some anastomosis between the two, and this is what is creating an opticociliary shunts, right? It's a typical triad, it's a part of a triad. Yeah. And of course, we come to this one, this is an MRI finding. What do you see? The yellow arrow here, this shows you the bullseye appearance. And why different? Because the sections are different. This is a coronal section where you see a bullseye appearance, okay? And when you do take an axial cut, in the axial section what you see here is, this is called tram track appearance. This is your tram track appearance, right? And this is the CT scan, and as I just told you, you get a tubular enlargement of the optic nerve. And sometimes there can be calcifications inside this. This is again very important as in the exam. Coming to treatment, of course, if I am fiddling with the tumor, I will damage the nerve. So, always the first line is observation. If you see it is growing and we can't help it, then only we go for surgery, okay? If it is going fast, you have to remove it, because otherwise it will be risk to the life, right? We next talk about is optic nerve gliomas. So, what are glial cells? All the non-neuronal cells of the nervous system are called glial cells. Just remember like this, okay? So, all the non-neuronal cells, I hope you are writing, all the non-neuronal cells of the nervous system, these are called glial cells. So, what are the name of different glial cells? Oligodendrocytes, astrocytes, ependymal cells, microglial cells, neuroglial cells. They are all different types of glial cells. We have to remember that optic nerve glioma is tumor of astrocytes. So, it's an astrocytoma. Got it? Hope you have noted down, right? So, this is one important thing that we'll keep in mind. And what did we learn? It is more common in female children. More common in females and in children. Next point, it is very slow growing tumor. Okay, it's a very slow growing tumor. And of course, it is associated in patients of NF1, more common in patients of NF1. And yes, it is more commonly, one more point, unilateral. More commonly, it is unilateral. Of course, the clinical features exactly the same as I explained you. that initially all the 5 signs of optic nerve disease, when the tumor is small, you are getting all the signs of optic nerve disease, and when it enlarges, it pushes the eye out, leading to proptosis. So, proptosis is a late feature, right? Then they have asked you most common pathological type. I think I mentioned earlier also, most common pathological type of optic nerve glioma, you will answer is pilocytic astrocytoma. Okay, so these pilocytic, when you look at, these are spindle shaped cells. These are pilocytic astrocytoma, these are spindle shaped cells. So, on CT scan, what you see is fusiform enlargement of optic nerve, right? Will not forget, this is your fusiform enlargement of the optic nerve. Treatment same, observation, if nothing is happening, it's growing fast, if you feel now it's growing faster, otherwise just call the patient on follow-ups. Let the vision be retained as much as it can. If we fiddle, we are going to land up into loss of vision. So, first line is always observation, and if it is growing fast, the next is surgery, right? Okay, so now we were talking about NF1, NF2, let's talk of features of what are the ocular features in NF1, let's talk about the ocular features in NF2, okay? When you say NF1, there is an exam question here, most common ocular feature, leash nodules. As you can see, these are hyperchromic areas on the iris. These nodules are called leash nodules. They are hyperpigmented. Okay? These are hyperchromic nodules. What are the other features of NF1? We can very nicely learn it with this mnemonic ocular. So, ocular, O, orbit, right? C, what happens in cornea, U, uvea, L, lid, A, angle, R, retina. So, it is all locations, okay? So, orbit mein what you are getting? Optic nerve gliomas, right? Cornea, prominent corneal nerves. This is mainly due to thickening of corneal nerves. This is nothing but thickening of corneal nerves. And uvea, this is your leash nodules. We have just learnt. Then comes your lid. What do you get in a lid? Neurofibroma, which leads to this S-shaped deformity. Okay, so this is your plexiform neurofibroma. We call it. So we call it plexiform neurofibroma, leading to S-shaped deformity of the lid. S-shaped deformity. Then angle, of course, angle anomaly, which is leading to glaucoma. And in the retina, it is retinal astrocytomas. You can get in choroid also, but here if we talk about retina, it is retinal astrocytoma. Right? Choroid is different, of course. Okay, so these are some ocular features of NF1 that we can keep in mind. What is asked in the exam is thickening of the corneal nerves, leash nodules, and S-shaped deformity of the upper lid or lid, which is involved. This is mainly, these are the 3 things which are asked from NF1. NF2, which is the most common ocular feature? We will answer presenile cataract or posterior subcapsular cataracts, right? So, this is the most common ocular feature. Second, of course, we just learned in meningiomas as associated with NF2. So, this is easy to learn. We get optic nerve sheath meningiomas. And apart from that, epiretinal membranes and ocular motor defects. Just learn the first 2, this is most important, that is one is PSC and second is your optic nerve sheath meningiomas. So, if you talk about for diagnosis of NF2, what are the main basic points? There should be bilateral acoustic neuroma, isn't it? With positive family history, with all these ocular features, with the ocular features. This is how you diagnose a NF2 case. Right? Yeah. We come to the next heading, blowout fractures. Very important for your exams. Let's understand blowout fractures. What have we learned till now? Blowout fractures are floor fracture due to blunt trauma. This is the first thing you will understand. There is a question, which is the most common site of floor fracture or weakest part of the floor. So, what will you answer? Weakest part of floor. Weakest part of the floor, not the weakest wall of orbit. Weakest part of floor, if they ask you, this has been your exam question, we will answer posteromedial part. Okay, posteromedial part. Right. Next we talk about is, of course, weakest wall, medial wall. And if that is broken along with blowout fracture, that is always a possibility. Okay? We'll talk about it. Right. So, when you say blowout fracture is floor fracture due to blunt, which trauma? Blunt trauma, generally due to blunt traumas. We will specify it here. And the most common site is your posteromedial. Now, there are two terms, pure and impure. What is a pure fracture? When no rim is involved. Rim involvement is not there. No involvement of infraorbital rim, it is called a pure fracture. And if infraorbital rim is also involved in the fracture, now you call it impure fracture. What are the clinical features? So, next we talk about clinical features. So, we start thinking outside to in, if this is the way there is a blunt trauma leading to the fracture, what all you can see in the patient. So, number one, if you look at this patient, what you see here there is a trauma with a periocular ecchymosis. So, write down number one is periocular ecchymosis. Now, periocular ecchymosis, this is what is called black eye. This is black eye, but do not call it panda eye or raccoon eye. Pay attention, the term panda eye or raccoon eye, this term is mainly used for fracture base of skull, because typically then the finding is bilateral. So, we just say fracture base of skull. That is first point. What is the next finding? You see that the sensation of the cheek is less. So, decreased sensation on affected cheek. Now, how do I come to know that the sensation is less? Now, and why it is so? This is due to damage to infraorbital nerve. So, infraorbital nerve damage. This is happening due to infraorbital nerve damage. How will I test it? What do you do? Take a cotton wisp, ask the patient to count 1, 2, 3, 4 once you touch the cotton on one cheek and on the other cheek. His eyes have to be closed, of course, and then you will see that once he is counting, he starts missing on the affected side. So, this is how we know that the sensation on that side is less compared to this side. What is the third point? As you can see it here very clearly, there is enophthalmos, right? So, the next number 2, number 1 was periocular ecchymosis, number 2 we learnt is decreased sensation on the cheek, number 3 we will talk about is enophthalmos, eye goes inside. In Horner's you also learnt enophthalmos, but that was apparent, right? कि देखने में लग रहा है. It's not actually true, but here now this time it's a true enophthalmos. What next? The patient, when he is looking up and down, can you see here is this restricted eye movement upwards? Why is the eye movement here restricted? And this is going to lead to diplopia. Number 4 point is diplopia. And why is this restricted? Why? Because there could be some, either there is diplopia and any restriction is causing diplopia. So, this diplopia, think with me, either there is any entrapment of muscle, isn't it? If the muscle is entrapped in the fracture side, there is restriction of movement. So, either there can be entrapment of muscle, or there could be actual muscle injury, or it could be just hemorrhage and edema, which is just restricting the movement as of now. That is soft tissue injury, right? So, that is causing hemorrhage and edema is also causing rest. So, these could be 3 causes why this patient is getting diplopia. Okay? Is there anything else we are missing in the features? Yes. I told you the weakest wall is the medial wall. So, if the medial wall is involved, we can get the ethmoid sinus will open. It's the lamina praepatia which breaks. Therefore, you can get subcutaneous emphysema. So, the next feature we will note down, number 5. The patient can have subcutaneous emphysema. Right? Okay. So, let us quickly revise. This is what? Number 1, periocular ecchymosis, then cheek numbness, enophthalmos, diplopia and subcutaneous emphysema. This is what you have learned now. Now, you are more, first was thinking and learning and understanding, and here is the recap. Okay. Now, there is another exam question. Which muscle is entrapped if it is entrapped? So, inferior ही होंगी ना, either inferior rectus or inferior oblique, but more commonly it is mainly inferior rectus. Okay, so primarily we will prefer to answer inferior rectus if both options are given. Otherwise, any of the inferiors can be entrapped. And one more point that when we are talking about the muscle, we have to keep in mind, sometimes due to the injury, there can be such a pull in the muscle that it may incite oculocardiac reflex. Where did you learn this oculocardiac reflex? We learned oculocardiac in squint surgery, that when you are handling with the muscle and dealing with the muscle surgery, there can be oculocardiac reflex which can cause bradycardia in the patient, and it may even lead to, it can be as serious as causing cardiac arrest. Similarly, here when there is an injury, sometimes the pull in the muscle can be so much, it can incite oculocardiac reflex. Okay, can we note down? So, let us note down here that any muscle pull sometimes can lead to activation of oculocardiac reflex, and that oculocardiac, that will lead to either bradycardia or cardiac arrest. Note down. So, where is the afferent? Trigeminal. Efferent is vagus, isn't it? So, afferent in this reflex, we have learnt it in squint chapter in detail about it, that afferent is trigeminal and efferent is vagus. Okay, when we were talking about the different types of fractures, one more point which I missed is, what is the mechanism? Why is there any fracture? When there is such a big impact, what happens with this? There is a buckling effect. So, just remember the mechanism of the fracture. If they ask you, it is buckling effect, right? Then coming to investigations. How can I see the floor of the orbit? With X-ray, I can do it with which view? Waters view or PNS view, or I can go for CT scan. So, in both the situations, whether I am doing a CT scan or I am doing an X-ray, PNS or Waters view, what I get here is an opacity in the against the background of maxillary sinus, and this is what is called teardrop sign, right? So, if you want to make it on a copy, you can make this diagram, that if this is the maxillary sinus, this is the orbital floor fracture. Due to this edema hemorrhage, there can be opacity against this black background. This is what is called teardrop sign. It's a repeated question of your exam. Okay? Coming to the treatment part. Treatment, you see, majority of the cases may be a simple fracture. Fracture will heal, it will take its time. Just manage with some medicines, antibiotics, anti-inflammatories. But suppose even after 10 days of these medicines, the fracture, there is no improvement in the symptoms, no improvement in enophthalmos, no improvement in diplopia. In that case, we have to shift to surgery. And why there is no improvement? Definitely there is some muscle entrapped in between, that is why it is not healing. Okay? So, the next question that they have asked you is about about the treatment of, what are the indication of surgery in blowout fracture. So, let us talk about that. So, treatment. What did I say? Initially, the first step would be this. This is the first step, that is, we go for antibiotics and anti-inflammatories, right? And if this is not, if no improvement, very important exam question hai, no improvement in diplopia and enophthalmos. In diplopia and enophthalmos, then I am going to shift to surgery. Are there some other indications of surgery here? Yes, either the enophthalmos is too severe or the fracture is too severe. Even then we can directly go to surgery. Why there is no improvement? As I just explained you, this can happen if there is any muscle entrapment. I hope this is clear to you, right? So, this was about blowout fractures. Okay, so next we talk about, give the heading, what are the surgeries to remove the eye? I know it's not very pleasant, but we have to know this. What are the surgeries to remove the eye or eye removal surgeries? One is your enucleation. What is exenteration and what is evisceration? So, this is asked and you have to know it. First is enucleation. What is enucleation? This is your first question of your exam. What is enucleation? Definition. So, we will learn it like this. Enucleation is, make the diagram. Of course, nucleus is eyeball. We are removing the whole eyeball, but along with that, maximum part of optic nerve. Okay. So, removal of the eyeball with maximum part of optic nerve. This is first question. So, we will learn what is enucleation is removal of eyeball with maximum part of optic nerve. When you have removed this, you have created a space in the orbit. If I don't do anything about it, it will be filled with granulation tissue. So, within 10 days or sometimes even in same sitting or in the same sitting, if we are using a hydroxyapatite material, I can use in the same sitting, I am going to put orbital implant. So, orbital implant is covering this empty space in the orbit and forming a base. Over this, I have to put the prosthetic eye, but for that I will wait for 4 to 8 weeks for it to heal completely, and after 4 to 8 weeks, I will put prosthetic eye. Got it? Now, this is also exam question, when to put prosthetic eye. This is also exam question, when to put orbital implant. So, you have to be alert here. So, 3 questions covered. Got it? Okay. What are the indications? Any cause of painful blind eye, you can do enucleation. Any cause of tumor in the eye, you have to remove the whole eye then. So, what is phthisis bulbi? Phthisis bulbi is blind shrunk eye. I mean to say, it's a blind shrunk eye. This is what is phthisis bulbi. Right? And what is the contraindication? This is asked. We should not do in panophthalmitis. What is panophthalmitis? When all the 3 layers of the eyeball are involved, infected or inflamed. What is endophthalmitis? When only the inner coat, retina, vitreous, this is involved, is endophthalmitis. So, when there is a panophthalmitis, if I do this, there is a risk of spread of this infection, and this is the reason we avoid it. This is how an eye looks like after enucleation. Next we talk about is exenteration. Next heading is exenteration. So, what is exenteration? We will again make a diagram and learn, and let us note on the diagram itself. Exenteration means, think with me, you are doing this surgery when there is any malignant tumor in the orbit. You don't want it to go to the brain. Naturally, you are going to remove everything from the orbit, isn't it? Similarly, when there is any lid malignancy or orbital malignancy, or it can be mucormycosis, which is also life-threatening. So, these are actually the 3 indications you just learnt with me, that this mainly the surgery is done in any orbital malignant tumors, right, or it could be lid malignancy, or it could be your, what did I say, mucormycosis. Okay? These are the main indications of this drastic surgery. What do you do here? You have to remove all the orbital contents. Right on the diagram itself, removal of all orbital contents. Right? Then what is the next step? Next step is periosteum is also stripped. Even this periosteum is stripped. Periosteum is stripped. Right? And third part, lids are cut. Lids are cut. Okay? So, this is your exenteration, or we can call it total exenteration. So, all this comes under the definition of total exenteration. We have 2 more terms. What is partial and what is extended? So, when you say extended, it is more than this total. In that, even the bone is removed. That is extended. Okay? So, when bone removal is included, it is extended. And what is partial? When we preserve the lids and the orbital apex, this is called partial exenteration. So, one was total, one is which you have just learned with me, one is partial, one is extended. Easy to learn now? Okay, let us write it more nicely. So, this is your total. Yeah. Okay. Okay. So, once you know this type and you know the indications of exenteration, what do you do after the surgery? What can we do? Everything is gone. If I talk about total exenteration, only thing is we can go for, to make it little better, is go for grafting or spectacle prosthesis, where it is on the specs that the shape of the eye is made just for cosmetic purpose. So, we will say we can go for treatment is grafting and trying to make it cosmetically better, or spectacle prosthesis. Okay, so this is the eye where this is the exenteration, and after exenteration this is how it looks like, right. Next is your evisceration. When you say evisceration, now again let us learn what is evisceration is. If these are the lids, this is the cornea, viscera, removing the viscera. What is viscera? All the intraocular contents is viscera. So, you cut the cornea at the limbus and throw it away. Looks so horrible to even, it just sounds so horrible actually. So, but yes, you have to cut the cornea, remove it, scoop out everything from inside, right. So, here what we do, we are scooping from inside. Making it again please. This is the cornea, cut the cornea. Then I said we scoop from scoop the intraocular contents, right. Intraocular contents, that is your, we are talking about uveal tissue, the vitreous, retina, everything is coming out. We are only left with the outermost coat of the eyeball, and that is the sclera. Either stitch it, if it is infected, just leave it. This is called evisceration. You are leaving the outer sclera, this is evisceration. But sometimes if the sclera is also inflamed and infected, we want to get rid of maximum part of the infected part. Then what you do, you cut the maximum sclera, and now only a small frill of sclera like this is left behind. If only a frill is left behind, this is what is called frill excision. So, when do you do it? When the sclera is also inflamed. Therefore, the indication of frill excision is, exam question, pan or enophthalmitis, panophthalmitis, right. And after this again what we use here is artificial eye, which we call scleral shells, right. Now, talking about when you say indication of evisceration, so the Jenov says very clearly that all the indications of enucleation are same as evisceration, okay, except a few conditions where evisceration is contraindicated. Can you think of something? Let us first talk. Any intraocular malignancy, if you do evisceration while scooping, you are going to leave the malignant cells. So, never do it in malignancy, and also never do it to prevent sympathetic ophthalmitis. What I mean to say here, if you all remember your sympathetic ophthalmitis, if one eye is having a perforating injury, uveitis can happen in the other eye. Suppose that injury is irreparable and you have to remove the eye, then please don't do evisceration, because again while scooping you can leave some uveal tissue, and it is the autoimmunity towards this uveal tissue that is causing the uveitis in the other eye, that is sympathetic ophthalmitis. If this is a situation and you have to remove the eye, go for enucleation, so the other eye is absolutely not affected. Got it? Yes. So, this is what we learn. If you talk about the indications, it is almost the same as enucleation, that is your painful blind eye. Yes, this time I can do it in panophthalmitis also. Sometimes it has a better cosmesis, so we can do this one. And of course, sometimes in bleeding and tear staphylomas, that can another be added here. And tear staphylomas, you can go for evisceration. You don't need to mark up all the, just remember almost the same. Only contraindications, if you remember, it's easier. For enucleation, it is panophthalmitis. For evisceration, very important, never do it in malignancy and never do it in to prevent sympathetic ophthalmitis, right? Yeah. So, these were about the surgeries to remove the eye. This is how eye will look like after evisceration. The sclera is left behind. Okay, let's solve a few MCQs here. I hope you enjoyed the chapter. So, which muscle is most commonly affected first in thyroid eye disease? Very important question. It's of course inferior rectus. We have discussed this. Which cranial nerve is first affected in cavernous sinus thrombosis? It is the sixth nerve, because it is in the body of the sinus. And of course, a blowout fracture typically involves which part of the orbit? It is the floor of the orbit, right? Okay, I hope you enjoyed the chapter, guys, and keep working very hard, and please keep writing along with me and making all the diagrams again and again. I think in every lecture I remind you all the picture memory will play a very major role in retaining things. Don't forget to make your Qs and double Qs in the copy. That's very important, right? So thank you so much. Stay blessed and keep smiling.